It really hits you when you see the numbers older adults. They're the fastest growing population group right here in Canada.
Mm-hmm.
And when you think about what that actually means, like on the ground, it's that pretty much every single physician, doesn't matter what their specialty is, they're going to be caring for patients in this group.
Yeah, with their own very specific health needs. It's a really significant shift.
So how does medical education keep up?
Well, that's the thing. It has to be proactive. We just can't rely only on geriatricians. All physicians really need a solid foundation in caring for older adults.
Right, to give the best care possible.
Exactly.
Which actually brings us right to what we're talking about today. We've got this really fascinating study that tackles this head on.
Okay.
It properly dives into the core abilities, the competencies that Canadian medical students should have to, effectively care for older adults.
And it's timely, you're saying?
Extremely timely.
Yeah.
Because the last big update to these guidelines was, get this, 2009.
Wow, 2009. Yeah, think about how much has changed since then. Medicine, our whole understanding of aging.
Totally. Things like progress in dementia understanding, much more focus on tailoring care, technology, and healthcare.
Right. So an update is, it's pretty crucial to make sure training actually reflects current knowledge, the best practices in geriatric care.
So for everyone listening, this is basically a shortcut. We're going to unpack the essential knowledge, the skills that are now seen as vital for future doctors in Canada caring for older adults.
And even if you're not in medical education yourself.
Exactly. Even if you're not, understanding these priorities gives you a really valuable window into how elder care is changing. What the key focus areas are going to be.
Yeah, it gives you a kind of framework for understanding what to expect maybe from healthcare professionals when they're caring for older people. That can be incredibly helpful just navigating the system.
Okay, so the study itself, it's called the Aging Care 5Ms Competencies, a modified Delphi study to revise medical student competencies for the care of older adults.
Bit of a mouthful, but descriptive.
Yeah. And like we said, the main goal was updating those 2009 Canadian Geriatric Society CGS core competencies.
And they didn't just, sit in a room and decide. They used a really interesting, pretty rigorous method. It's called a modified Delphi process.
Delphi process.
Think of it like gathering input from a national panel of experts, but doing it through several rounds of surveys. This happened over a couple of years, 2019 to 2021.
So multiple rounds, national experts.
Yeah, it allows for a really broad range of perspectives to be considered, and it builds consensus systematically.
Okay, let's dig into that Delphi process a little more. Like, what did that actually look like? How does it work?
So imagine you need feedback from a bunch of specialists on something complex, right? But you want to avoid, say, the first person who speaks up influencing everyone else too much.
Okay. Anonymity at first.
Exactly, at least initially. So in this study, there were 3 main rounds. Round 1 was sort of identifying the big important areas in elder care, broad strokes. Then round 2, they presented specific competency statements, things doctors should be able to do. And the experts rated how much they agreed with each one, like on a scale.
Okay, so getting quantifiable feedback.
Right. And then the third round, refine those statements based on all that feedback and the levels of agreement. So if most people agreed something was vital, it stayed in. If there wasn't much agreement, maybe it got tweaked or dropped. It's a way to build a really well-considered consensus.
That sounds like a really smart way to arrive at a thoughtful set of recommendations.
It's quite robust.
Now, the study also mentions using 2 key frameworks, the Geriatric 5Ms model and the CAN-MBS framework. What are these about? How do they help shape things?
Right. These are really foundational. The Geriatric 5Ms model, it's a great lens for looking at the core aspects of care for older adults. The M's stand for mind.
Okay.
Mobility, medications, multi-complexity.
Multi-complexity.
And the last one, maybe the most important, what matters most to the patient.
What matters most. I like that.
It's very patient-centered, isn't it?
Yeah.
Because it forces you to think about how these different areas are all interconnected and how they influence an older person's actual health and well-being.
So seeing the whole picture, including the patient's perspective, makes sense, and the CAN-MBS framework.
So CAN-MBS is basically the standard framework used across all Canadian medical education. It describes the essential abilities all physicians need, but it organizes them into 7 key roles.
7 roles.
Medical expert, that's the obvious one, but also communicator, collaborator, leader, health advocate, scholar, and professional.
Okay, so it's broader than just medical knowledge.
Exactly. By aligning these new geriatric competencies with those broader CAN-MED roles, it ensures they fit neatly into the overall expectations for doctor training in Canada. It underlines that being a good doctor isn't just about knowing the science, it's also about, communicating well, working in a team, advocating for patients.
Okay, that makes a lot of sense. So we've got the context. Growing need, updating needed. We've got the process. This rigorous Delphi study using established frameworks like the 5Ms and CAN-MDs. So let's get down to it. What actually came out of this? What were some of the key areas, the competencies themselves, that emerged as crucial?
Yeah, let's get into the specifics. So the study ended up with 33 specific competencies, all organized under those 5M umbrellas we just talked about.
33, okay.
Yeah. Let's take a few examples. Under mind, one really key competency is being able to recognize and, crucially, tell the difference between conditions like delirium, dementia, and depression.
Which could look similar sometimes, right? Especially in older adults.
Exactly. And the experts really stress the subtle interplay. Like a seemingly minor infection might trigger delirium, this acute confusion which could easily be mistaken for, say, dementia getting suddenly worse.
Ah, I see. Recognizing those acute changes is critical.
Absolutely. It's a critical insight for any doctor caring for an older person. Without specific training, those could be easily confused, leading to very different, maybe wrong management plans.
Yeah, I can see that. What else under mind?
Well, building on that, another competency focuses on identifying and then addressing safety concerns that come up because of cognitive impairment.
So not just diagnosing, but the practical implications.
Precisely. It's about understanding how that cognitive change might increase risks in their daily life, like falls at home, medication errors, and knowing strategies to help mitigate those risks.
Okay. And mobility, that's another fundamental M, right? What came up there?
Yes. Huge emphasis here. Being able to screen older adults for their risk of falls, that's a big one.
Is asking about falls.
More involved. More involved. Identifying the specific factors contributing to that risk could be muscle weakness, vision problems, medication side effects, even hazards in the home.
Right. It's often multifactorial.
It usually is. And then developing and implementing strategies for prevention. There's also a focus on assessing their functional status.
Yeah.
Their ability to do everyday things like dressing, bathing, preparing meals.
And doing that assessment, is it just the doctor?
No, and that's key. Doing this in collaboration with other healthcare professionals, physiotherapists, occupational therapists, people who have really specialized expertise in mobility and function.
It really sounds like a team-based approach is baked right in.
It has to be, doesn't it? Given the often complex needs, collaboration is absolutely essential.
Makes sense. Okay, what about medications? That seems like a big one for older adults, too.
Oh, definitely. A core competency here is the ability to take a really thorough, best possible medication history.
Best possible medication history. What does that mean exactly?
It means really digging deep to find out everything someone is taking. Prescriptions, yes, but also over-the-counter stuff, vitamins, herbals,
right?
Everything. And then being able to conduct structured medication reviews.
Like going through the whole list.
Yes, a comprehensive look. Is each medication still needed? Is the dose right? Are there potential interactions, side effects? This is so important because, as you know, older adults often take multiple medications.
Polypharmacy, right. We hear that term a lot.
Exactly. It's a huge challenge. So, related to that, other competencies include understanding how the body actually processes medications differently as we age.
Like kidneys and liver function changing.
Precisely. They might not work quite as efficiently. And also being able to identify medications that might no longer be the best choice, or even opportunities for what's called deprescribing.
Deprescribing, so stopping medication.
Safely stopping them, yes. Or reducing doses, under careful medical guidance, of course. It's like decluttering your medicine cabinet, but with your doctor's expertise to get rid of things that might not be needed anymore or could even be causing harm.
That sounds incredibly important. Okay, next, multi-complexity. That sounds complex. What falls under that?
It does sound broad, and it kind of is. It addresses the reality that older adults very often have multiple chronic health conditions going on at the same time.
Like diabetes and heart disease, maybe arthritis.
Exactly. And also dealing with what we often call geriatric syndromes, things like frailty, incontinence, falls. Things that don't fit neatly into one disease category.
Frailty seems key there.
It is. There's a specific competency around being able to identify frailty using proper assessment tools, because being frail can significantly affect how someone responds to illness, to surgery, to treatments.
Right, it changes their resilience.
Absolutely. Another crucial competency under multi-complexity is recognizing that common medical conditions can present in really unusual or atypical ways in older adults.
Meaning the symptoms aren't textbook.
Yeah. Like, a heart attack might not present with crushing chest pain. Maybe it's just sudden confusion or weakness. A urinary tract infection might not cause burning, maybe just delirium.
So it requires a different kind of clinical thinking, doesn't it? A higher index of suspicion.
Precisely. You can't just assume the symptoms will be the same in an 80-year-old as in a 40-year-old. The competencies also stress managing all these coexisting conditions in a way that's centered on the individual patient's needs and preferences.
Okay, tailoring the approach.
Yes, and also, importantly, recognizing when a palliative approach to care, one focused on comfort, quality of life, symptom management, might actually be the most appropriate path rather than aggressive curative treatments.
That's a critical conversation to be able to have.
Extremely.
Okay, finally we get to what matters most. This one really strikes me as sort of the heart of patient-centered care. What competencies fall under this crucial M?
You're right. This is where that holistic, truly patient-centered approach really comes through. It includes the ability to actually have meaningful conversations with patients and their families, too, to understand their individual priorities, their values, their goals for care. What do they want?
So communication skills are paramount.
Absolutely. But it also goes broader. It includes recognizing wider social factors that can hugely impact an older person's health.
Like what kind of factors?
Like, identifying inequities in access to care, systemic challenges they might face, understanding the impact of ageism.
Ageism, yeah, that's huge.
And the importance of advocating for their needs within the system. It's also about understanding the profound impact that things like social isolation and loneliness can have on health.
Which we know is a big issue for many older adults.
A massive issue. And finally, being aware of the key ethical and legal issues that often come up, things like capacity to make decisions, end-of-life care planning.
Wow. It really sounds like these updated competencies cover a lot of ground. They provide a very thorough and comprehensive roadmap, don't they?
That's the idea. Training future physicians to care for older adults in a way that's not just based on the best medical evidence, but also deeply respects their individual needs, their life circumstances.
So it's about being technically skilled and humanistic.
That was the fundamental goal, yes. The hope is that by getting these competencies integrated into medical school curricula right across Canada, we can ensure that all graduating physicians have a solid foundational understanding of the unique aspects of geriatric care, no matter what specialty they end up choosing.
Okay, so let's try and bring this all together. It seems clear, with Canada's population aging so rapidly, making sure all doctors are equipped for high-quality elder care is just more critical than ever.
Couldn't agree more.
And this deep dive in these updated aging care 5Ms competencies, it really highlights a shift, doesn't it, towards a more standardized, comprehensive approach.
Yeah, built on that strong foundation of the 5Ms: mind, mobility, medications, multi-complexity, and what matters most.
Right, and all fitting within that well-established CANMAS framework for what makes a good doctor overall.
And I think what's also really insightful is the process they used. The fact that these 33 specific abilities came out of that rigorous modified Delphi study.
Yeah, the multiple rounds, the expert consensus.
Exactly. That iterative process, it really underscores a commitment to developing guidelines that are practical, relevant to today's practice, and actually supported by people working in the field.
And you mentioned something interesting earlier, that some topics didn't make the final cut as high priority.
Yeah, that was interesting. Some topics you might think are core, like detailed theories of aging, were actually deemed lower priority for medical students specifically by the experts involved.
Huh. Why do you think that is?
Well, I think it points to a really practical focus. The emphasis seems to be on the immediate day-to-day knowledge and skills needed for caring for older adults, rather than deep theoretical dives that might be more relevant for, say, a research scientist or a specialist geriatrician.
Okay, so it's about what every doctor needs to know right out of the gate.
I think that's the idea. What they truly need to know and be able to do to provide excellent frontline care.
So for you, listening at home, understanding these competencies gives you a pretty valuable peek into the future of elder care in Canada, wouldn't you say? These are the priorities being set for the medical professionals who'll be caring for older adults in the coming years. You know, if you have an aging parent, knowing that future doctors will be specifically trained in things like comprehensive medication reviews or assessing fall risk, that can be quite reassuring, right?
It provides a context for expectations, yeah. And maybe raises an interesting question for listeners to think about.
Oh, go on.
Well, how might a greater emphasis on these 5Ms, mind, mobility, medications, multi-complexity, and what matters most, how might that influence your own understanding and expectations of care for older adults in your life, or maybe even for yourself as you age?
That's a good question. Like, which of those M's resonates most strongly with what you personally think constitutes really good elder care?
Exactly. Is it the focus on mental well-being, maintaining independence through mobility, getting the medications right, managing all the complexities, or really honing in on what matters most to the individual?
It's definitely something worth mulling over.
Yeah.
And, if you are interested in exploring this a bit further, you might want to look up the geriatric 5Ms model itself, or the CAN-ME-S framework.
Yeah, they offer even more context for the principles that are guiding how we train healthcare professionals right here in Canada. It gives you a deeper understanding of the thinking behind these competencies.
A great suggestion. Really helps frame the future of care.